Good afternoon, everyone. Try again. Good afternoon, everyone. All right, my name is Amit Mistry. I'm with the National Institutes of Health within the Fogarty International Center, and it's my pleasure to welcome you to the last plenary. Hope you had a good lunch, and I'm gonna be borrowing a few attributes of the previous panel. So I'm gonna start with a joke. So why was the data scientist digging a hole? Why was the data scientist digging a hole? Because he wanted to get into deep learning. All right. I didn't say it was a good joke, but all right. So again, it's my pleasure to welcome you to our plenary on strategies for effective and equitable partnerships. We have an all-star panel lined up for you today. And okay, sorry, that's too far. All right, I wanted to just share a few numbers about partnerships within and outside the DSI Africa Consortium. And a big thank you to Gifty Danke for putting these numbers together. We now have 38 projects or awards within the DSI Africa Consortium. And of course, each of those awards comes with their own core partners, a total of 134 core partners. We've also, thanks to your reporting to your program officers, we know of at least 49 intra-consortium linkages and partnerships, which is really great to hear about. And also through your reports that you've been submitting, we've counted at least 108 external partnerships and pilot projects. So a big round of applause for all of you for really taking this message to heart. And I also wanted to, before we get into today's discussion, I just wanted to put in a plug for the Partnerships and Outreach Working Group. This is a unique working group because it is open to anyone within and outside the consortium. You're welcome to sign up. Another QR code for you here. The working group serves as a venue to create networking opportunities, as well as a forum for discussion about challenges and strategies around partnerships, much like what we'll be discussing today. So if you haven't already, please consider signing up for the Partnerships and Outreach Working Group. And if you have partners that you're working with who are not already part of the consortium, encourage them to sign up too. It's a great way to get engaged with the program, even if you're not a grantee. And now to give you a sense of how today's session will work, we're not exactly following the agenda that you have in your schedules. We're making a few adjustments, but we're going to start with a keynote who's going to speak very broadly about partnerships and what it means to collaborate. And then we're going to have 5 DSI Africa projects, and we've ordered them in kind of broad topics to more narrow topics, and more broad definitions of partnerships to more focused types of partnerships. So we're going to start with a discussion on the need and the importance of partnerships for data science. Then we'll get into examples and issues related to international partnerships. We'll move into a discussion of partnerships across cultures, multicultural partnerships. And then we'll talk more specifically about engaging with public health officials, as well as community groups, religious community groups in particular. We're gonna, again, ask you all to save your questions during all the presentations, and we'll bring all the panelists up here for hopefully a lively discussion. And if we have time, we're gonna try to do a small group activity, but we'll see how the afternoon goes. And then we have our new co-chair for the Partnerships and Outreach Working Group to help tie things together at the end. So with that, I'd like to introduce our keynote speaker, Anne Mwangi. Anne is the Associate Professor of Biostatistics at the School of Science and Aerospace Studies at Moore University, where she's been working with students, undergraduate and graduate at the College of Health for more than a decade. She's also the co-director of the AMPATH Data and Analysis team, where she's involved in data management and analysis of a variety of research projects. She is a co-PI for the NYU Moy Data Science for Social Determinants Training Program, or DSSD. And she has a wide variety of research interests. Today, she's going to be talking to us about what it means, what collaboration really means, and bringing in some of that expertise from the ANPATH program. So as before, please join me with a round of applause to welcome Anne to the stage.
Good afternoon. Yeah, first is to thank the organizers for giving me an opportunity to speak at this very important meeting, focusing on DSI in Africa, and more so thinking around the issues to do with partnerships and how do we ensure equity. And for my talk this afternoon, I'll just briefly describe some of the current trends in collaboration research and highlight some few pitfalls that may occur whenever we're doing collaborative research, and more so thinking in terms of research integrity, and more so because I see it in the Moi University Research Ethics Board. And I'll also highlight one of the programs we've been working on in terms of building biostatistics partnerships within Moi University. And I'll also highlight another important partnership that focuses on South-South collaboration that we are also working on. So basically, when we're thinking about collaborations, it's all about partnership. And I want us to know, I know majority of the time we're thinking in terms of North-South partnerships, but it's also important for us to start thinking even around how do we engage even our collaborators within our own setting, even within South-South. And this comes into play, especially thinking of the context where I'm coming from, whereby in Kenya currently we have devolved health. Meaning whenever I'm working, I'm not just collaborating with the northern partners, but I'm also collaborating with the county governments that have a lot of implications on the work we do. So I know here we are all talking about partnerships. There are new DSI projects that have come in, and we're also all thinking about how do we collaborate, how do we work together. So I think I just wanted to highlight within this that we are not just thinking in terms of global South and global North. And I know that terminology also has some intonations to it. And I think, so that's why I wanted to highlight that specific angle as we are also thinking about partnership, not just necessarily North-South, but also South-South. And even within our context, how do we work with the counties, for example, in my setting. And global health partnerships have been around for quite some time, for more than 20 years. And there has been a lot of growth in this, mainly due to increased availability of funds. There's also the aspect of responses to HIV in sub-Saharan Africa. And also in terms of the complexity of the researches we do, it's hard to work on our own. And global health partnerships are also becoming very, very important. Mainly, again, in our context, especially in sub-Saharan Africa, the resources we have are still very limited to be able to address the public health needs that we have. In addition to that, we've also seen challenges, issues to do with Ebola, COVID, which is not necessarily a one country problem, but it needs to be tackled from a global perspective. Again, we know that partnerships are also important because they've been shown to be important mechanisms when we're trying to achieve the SDGs and also in improving the health of our populations. But as we think about partnerships, we've all been talking about issues to do with equity, issues to do with equality. And from this diagram, as you can all see, the first one shows around issues of inequality. But even as we try to think about enhancing that and ensuring there's equality, we also have to think about issues of justice and issues of equity, because you can have the tools necessary to do what you need to do, but the opportunities equal, even as we are approaching these problems. So I think as we think about this, for me, this is a very important thing to think about, as we also highlight the other social injustices that have actually happened within collaborations or within partnership. The first one being the issues around ethical dumping. And this is actually a big challenge that we have been seeing, but I'm glad that over time, our ethics board are also getting more conversant, and we're improving in terms of how we do even our reviews to be able to address this important aspect. And as I highlighted, this is not just issues to do with North-South, but also even within our own setting. How do we tackle this issue of ethics? And when we are reviewing our proposals and reviewing the projects that are coming along, to ensure that we are not just doing researches in a specific setting just to evade some things that we would not do elsewhere. So, and also a lot of times we see the standards being lower in some settings compared to some other settings. Other examples are to do with helicopter research, which I think has also been highlighted during this important workshop. Again, this forgetful friend, I'm sure we've been talking to each other and trying to see things we can do together, But I don't know, once we leave Kigali, whether we're still going to remember what we promised our friends that we would do together. And again, the other one is all to do with the RAPE model of research, where again, once I collect my data, do I still remember my partners that I worked with in the field, whether I go back and inform what they do in their daily places? And why are we concerned about these important aspects? And one of them is we still have to keep in mind, even as we do research, that there are some structural inequalities that we need to build in even as we engage in partnerships. And what precautions are we putting in place whenever we're engaging in these collaborative researches to ensure that we maintain that equality? And how do we address those structural inequalities in the work we do? Again, keeping in mind that we need to be aware of our populations that we are dealing with, being sensitive to the cultures, being sensitive to the language and how we apply that language in the work we do. And also the issue of the issues of how we deal with the colonial structures that are still embedded within the settings that we are working in, especially for developing countries. For our developed countries to still be ensured that they don't, that dominance and that superiority, how do we address it as we engage with our partners? The other angle, and I know a lot of the projects which we are doing, working on have a component to do with capacity building. And how are we approaching that capacity building? And is it a reciprocal relationship? Because I know there's the aspect of transfer assumptions as well as professional knowledge assumption. And for me, because, and I know I attended the session whereby the representative from the AIMS talked about that within our populations, we have geniuses who can be able to develop some of these models. And are we trying to ensure we may, even that traditional knowledge that already exists, are we able to build on that and not just think about how we can get knowledge from the other partners and bring in our own setting, but how can we utilize the knowledge that already exists? And how are we ensuring that even this aspect of transfer assumption, that poor countries cannot produce knowledge? But I still believe that we are able to produce knowledge so long as we have the opportunities are provided for us to be able to do that. And I'll highlight that at the end when we start thinking around how do you go about it even within our own setting. And this diagram shows the elements, that can enable or inhibit equity. And for me, especially if we are looking at this diagram and thinking around, especially the roots, if you think of this as a tree with many branches and also there are roots, the issues of misconceptions, I think, is one area that I think we need to think through as we engage in collaborations to ensure that those assumptions, we put them in considerations whenever we're engaging in research so that we can be able to enable equity even as we engage in partnerships. And again, the Swiss Commission has some 11 principles that could guide us as we collaborate. And number one, actually, it's something that has also been highlighted during the course of this workshop on how do we come up with the objectives? Do we work on them together or do we wait for objectives to be sent to us from the north and we just embed and say, yeah, good to go? And for me, this is also important. As I said, this partnership is not just to do with North-South, but also how do I work with the communities around me? Am I addressing their needs or am I addressing my own needs? Am I working with the county government, for example, in my setting, so that we work together on how we come up with the objectives to be able to address their needs so that they have their priorities. Am I addressing their priorities or am I the one who is dictating what their priorities should be? Keeping in mind that as we are working with governments, we need to have them, they also have some allocated funds so that even these new techniques or these new innovations we bring in, are they sustainable? And they'll only be sustainable if I'm meeting the needs or the priorities for the people I'm working with. Again, the issue of mutual trust, this has again is another very, very important one, and that we need to build and also strengthen in the collaboration and partnerships we already have. How do we share information? How do we share responsibilities? And I know even within the DSI that we are working with. We have the working groups. We have shared responsibilities across the working groups. Again, creating transparency, monitoring and evaluation, which again, it's one thing even within the consortium that I'm already working with that I'll highlight at the end that it's maybe something we should be doing better so that you can be able to monitor how are we moving even within the partnerships that we already have. How do we disseminate our results? Am I the person once I leave the field, the population I studied never get to know what is it that I found, or do I go back and let them know what is it that I found? And in addition to that, not just disseminating, how do we apply the findings that we come up with? And that's why we need to engage with these important stakeholders right from the beginning, because we can only apply these results in settings that it would work. And that's why for me, for sustainability, it's important to work with them from the beginning so that even the application aspect becomes easy. Issues of increasing research capacity. How do we even share the profits? Are we sharing it equitably? And also thinking about even issues to do with intellectual property, which again, I think will be key for the projects we are working on as we come up with new innovations. So these are just some highlights. And in addition to that, I think for me, it helps us to keep things clear. Yeah, as we engage in partnerships, how we communicate, the leadership aspect, yeah, the enthusiasm, yeah, is it just the key people person who came up with the objectives, and the other guys, since they did not contribute, they are not as involved or as engaged, because do they really care about even this work that we are doing? The agreements, which are also important, ensuring even the roles and responsibilities from the beginning have been clearly laid out. So as I said, I think that was just a global thinking about partnerships. But at this point, I think I've also looked at some key strategies that we could employ as we engage in partnerships and as we try to ensure issues to do with justice, issues to do with equity. And there was a scoping review that was carried out looking at North-South research partnerships. And within this, I mean, there are guidance that exist there, but it's not very clear on whether and how these guidelines are actually practiced within the North-South collaborations. So which is something I think it would be good, I think, to see how well these are applied and how we can apply even within the consortiums that we have today. Another one is again, looking at a systematic review, looking at authorship. And I think this again was highlighted by one of the keynote speakers about the fact that as research and collaborations have grown over time, within Global South and Global North, we have seen more and more engagement of authors from the South being incorporated in the list of authors. But again, even within this context, according to this systematic review, yes, the numbers have gone up. But again, it also matters which like university in the Global North you're working with, because for some universities that are top, you might find that fewer and fewer people from the South are incorporated in that authorship. And within this, they made some key recommendations of how can we increase more of the South-South collaboration. And in addition, how do we still ensure that even for the reviewers, journals, the funders, how do we ensure that this aspect is also taken care of, the aspect of authorship and also the contribution even within the funding mechanisms. So, and again, I think I'll highlight especially that aspect of South-South collaborations. Are they possible? Are they feasible? What does it entail for them to work? So again, as we are thinking about equitable research partnerships, we have to understand the ecosystem, build relationships, and also transform the processes, and also the aspect of even how the resources are allocated. Because as we saw, it's not just an issue of ensuring there is equity, but there's also the issue of justice to ensure the opportunities are the same. So now I shift gear and talk briefly about the AMPAT biostatistics experience, which is our experience building a biostatistics partnership. And I work with the AMPAT program, which is the academic model providing access to healthcare. And this is a PEPFAR-funded HIV care program, which is based in Eldoret, Kenya. So we are serving the western parts of Kenya. And within this care program, we have over 150,000 HIV-infected individuals who are in care in these facilities. And one key angle of AMPATH is has a tripartite mission, which is leading with care. Then we have the research and the training aspect. And for these 150,000 patients, we have an electronic medical record system that has data on several million encounters with data on their labs. We have, and data is stored in a central server, and currently we have the point of care data entry. And for the AMPATH model, we have this graph shows the trend in terms of funding, and the other graph on the, which would be, I think, on your left, would be the proportion and the number of publications. And as you can see, as the funding is going up, the publications are also going up. And I might have, it's important for me to highlight that majority of this funding is actually coming from the NIH, over, I think, 90% of this. And so this shows that as the funding is increasing again, the number of publications are increasing. And we've also tried to put mechanisms to ensure the authorship, that the Kenyans who participate in this research is actually first authors based on their level of contribution. And this has been through coming up with working groups for the different areas. And in addition, having what we call an AMPATH publication committee that reviews these grants and ensures there is equity in terms of contribution publications and who is the author in the publication, but also taking into account the contribution that is also important for one to be an author. So in terms of biostatistics, within this program, initially, there are several biostatistics needs definitely that comes in. One in the area of study design, and also putting together the grants, designing of the data capture, as well as managing that data, being able to create also data sets from the EMR. And in addition to that, contributing in manuscripts, abstracts. But I must say, I was the first biostatistician to join the program with master's level training. But with over time, we've found the demand has gone up. So there was importance for us to try and see how to fill in that gap. And so the gaps that were there was, number one, there was imbalance in the training and expertise because majority of the advanced work was being done from the north. There was also imbalance because the data is being generated, yes, from the south, but the analysis is happening in the north. In terms of authorship, again, majority of the contribution was coming again from the north. And again, we all know that in our setting, the undergraduate program is actually very, very strong, but more in the theory, but very limited in terms of application. And majority of what was happening at that point was more of application in agriculture. So this led to the Nambari project. But before the Nambari, I must say, because I highlighted the aspect of authorship from the south, again, even for the other researchers, not just biostatistics, was limited. And through the Fogarty A trip, we had training in the area of research for the researchers in TB, cervical cancer, among others. And that led again to improvement in terms of capacity for the Kenyan researchers. But again, there was still a shortage in terms of biostatistics. And that again led to incorporation of biostatistics within the Fogarty A trip. And I'm a Fogarty beneficiary from the A trip program. But following that, we also did apply for the D43, which is named Nambari. And Nambari is a word, Swahili word, meaning health through, we call it health through numbers. Nambari is numbers. And this is a Moi Brown partnership for biostatistics training, with the main partners being the Moi College of Health Sciences and School of Science and Aerospace Studies. We also have AMPATH because we need where our students can work on in terms of hands-on experiences. We also have the AMPATH Consortium, which is a network of Northern American universities that collaborate with Moi University, and Brown is one key member of that consortium. So the approach here, remember our goal was to increase the number of faculty and staff with high biostatistics expertise. And again, the other goal was to engage these faculty and trainees in HIV research at Moi. And the other thing we're interested in is to see how do we expand this already existing program that has a lot of theory, but no minimal application at Moi. And also we also did realize that a lot of statisticians in the South work in silos. How do we bring statisticians from the various programs together to talk to each other? So the approach we took for this was to recruit and enroll trainees to have master's training at Brown. And again, we also had a PhD training at Brown, but in our second phase, we also did think through about having PhD training also at Moi, but we augment with some trips and collaborations with Brown faculty. And then again, the postdoctoral aspect of training, both at Moi and Brown, faculty exchange to help improve in terms even of our curriculum. We also had the train of trainers and the summer annual workshop to bring in researchers and statisticians from the South together. So successes so far, we've had 8 MSc graduates so far. And we've also had these trainees. Actually, we've been very successful with them coming back to work with us. So most of them are still engaged and participate within AMPAD. Some have left, but they're still working on projects within Kenya. We've also been able to maintain and program and do researches within AMPAD. And we've also had the Moi University being very, very supportive of what we do, as well as AMPAD. We also have the new DSSD project that Rumi will be talking about. We've also had the train of trainers. And for me, the key highlight from this is the fact that our graduates are actually the ones who do the training, especially for faculty in the College of Health Sciences who need some advanced methods courses. We've also had 5 advanced training summer workshops, the representative from more than 7 African countries. And there are still gaps because the imbalances still remain in terms of training, authorship. Again, there has been still this question around how do we still guard from the white savior mentality? How do we deal with that? And for me, I think this is a key area whereby we need to see how do we do more advocacy so that even our own countries, how do we ensure they are also supporting the kind of work we are doing within our own setting? And I think I like this because one meeting we had in West Africa, we had someone saying, why is it that statisticians never want to be in parliament? Why don't they ever want to be in government where policies are being made? Where will our voice ever be heard? And again, this is not easy. And I know my counterpart from Brown is here. He has to make frequent visits to Kenya, which is again, is not something that everybody would want to do. With collaborations, we have to do frequent communications. As we said, communication is key. But this means we have to have conference calls, taking into account the different time zones. Yeah. And again, how many of our partners are willing to commit to that time coming to spend in Africa to support the work that we are doing? The other key question that I know we've been discussing this in this workshop, the issues around data sharing. How do we share our data? How do we use our data in training? So these are photos showing some of the summer workshops you've had, and one of the, yeah. So I know time is not on our side, but I just briefly wanted to talk about the South-South collaborations, because I think a lot of us here from the South, we need to see how do we build partnerships? How do we work together? And I'll highlight one consortium that Moi is now part of, which is the Sub-Saharan Africa's Consortium for Advanced Biostatistics. I know KwaZulu-Natal is also part of this. And this is work funded by the Wellcome Trust through the Delta program. And the objective of the consortium is actually to build master's programs, improve research and capacity building, and also network for training and research, and also see how we can support the statistical at the national level. And within this consortium, the current partnerships, we are focusing on specific health research strategy, challenges. So areas of HIV, areas of non-communicable diseases, maternal and child health, climate, health systems, and healthcare research. And we have representation from the South with WITS, KwaZulu-Natal, South Africa Medical Research Council, Then those are like the partner institutions, but we also have some collaborating institutions within South Africa that are listed down there. Then for East Africa, we have Moi University and Kemri Wellcome Trust. And for West Africa, we have University of Albany. And then we also have some Northern partners led by the London School of Tropical Medicine and Hygiene, and then Utrecht University in Netherlands. So this partnership is actually looking at how can we work within the South based on the capacity that currently exists in the ground. And the whole idea is we might have a student from KwaZulu-Natal who is interested in the area that Moi is focusing on, and they can have their student being at Moi and vice versa. In addition to that, we're exploring areas around co-supervision, co-teaching, so that we can be able to utilize the mass that currently exists within this. We just launched this second SACA partnership, but from the first phase, there are already some successes seen in terms of masters and PhDs. Also, now we have postdocs whom we are hoping the ones who the PhDs will be mounted within the various projects. And we are also definitely working with the research institute, because we realize that these students, once they are done, where do they go and work? And also, where do they go for example, their internship? Where do they get their data to be able to do their research? So in terms of way forward, I think I highlighted one of the things being advocacy. How do we get the government buy-in? We've been talking here, I think, around issues of open source, because we still know the structural inequalities that exist. How do we access the softwares that we need to be able to do the work we are doing? The aspect of synthetic data for training. Again, within AI, what I've seen in my country, people are thinking about quick fixes, but how sustainable are they? Yeah, the funding opportunities, I think we want to appreciate the DSI for thinking about data science and innovations in Africa, because I feel this is one area that is really going to help us in the South in terms of exploring, because we have the needs, and we need these funding opportunities to help us explore those challenges that we have. The FOCA D43 for the funding that we've continued to get to be for capacity building in Africa. In addition to that, I think because the issue of mentorship and also protected time for faculty once they're done with their PhDs. So again, the K43, I know some members from my consortium have benefited from this so that they can start their research journey. So I think for me, it's to appreciate all these efforts. So thank you very much.
Thank you so much. Thank you so much, Anne, for really giving us a great big picture, a lot of principles to think about, and some really powerful examples. Now we're going to hear from our DSI Africa projects, and I'll mention in our planning call, they all offered to shorten their presentations to give more time for Q&A and discussion. So I really appreciate them agreeing to keep their presentations tight so that we can have more time. And I'm sure as you have questions, please write them down. We'll bring everyone back together at the end for Q&A. So now I'd like to introduce our next speaker, Rumi Chinara. Rumi is a PI for the NYU Moi Data Science for Social Determinants Training Program, DSSD. She's also at NYU. She's also the director of the Center for Health Data Science and associate professor in computer science as well as biostatistics. Her research interests are in developing computational and statistical approaches for acquiring, integrating, and using data to improve population level public health. And Rumi today is going to be talking to us about a broad, big picture issue around the importance of partnerships for data science. So join me in welcoming Rumi to the stage.
All right, good afternoon. It's nice to be here with you all these few days, and thanks for having me for this talk today. So as Amit mentioned, I'll be speaking about the need for partnerships, specifically in data and data science. So thank you to Anne for setting us up very nicely, hearing about partnerships. And many of you know I have the pleasure of working with Anne on our NYU Moi Data Science for Social Determinants training program, and you'll hear a little bit about that as well. All right, so We know that diversity is really important in many, many fields, and it's been shown important for innovation in management, healthcare, economics, scientific discovery. And don't worry, you don't have to read all the small print at the bottom, but I wanted to show that there's a lot of scholarship that has really shown that diversity matters for innovation. And what I want to do today is bring us to data and data science and why that diversity is also important on this topic. So here's the data science workflow. We're all very familiar with it, and we'll hear from a lot of folks today, and we have all through the course of the meeting about partnerships in regards to identifying important problems. And I want to bring us to that next part on the wheel, which is once we have this idea of a topic, now when we are creating the data, how do we do that, and what does that look like? So I want to pose a very broad question to you. What is considered data? And on the side of the slide here is a socio-ecological model. And what this just shows in a multi-level kind of way is all the factors that influence our health, right? And so we're all concerned with data science in relation to health. We have, of course, in the middle, all the very important individual factors. So many things about us as individuals, our genetics, maybe my hypertension level, which is very high, our body mass index, if I'm smoking, my genetics, all of these are very important factors. Now, in addition to that, these are nested in other things. Like if there's many smokers in my family, it's more likely I'm also going to smoke. And there's other institutional, community, other settings, including policies. Like if there's a lot of tax on sodas, I might not choose to drink soda here and there. And so all of these factors will also relate to our health. Now, of course, these factors are also going to vary by place, right? What does it mean? What kinds of policies are important in one place versus another? What kinds of outside environments are relevant in New York versus Nairobi? It really matters on the place that we're thinking about as well. So I wanted to show an example of this. This is from one of the posters I just saw in the last couple of days in the poster session. Thank you so much, Mr. Achiri from the Yaoundé University, where he was studying asthma, especially in young adults. And you can see it. I'll just point out on the poster on the left bar graph, you see that tall white bar. And so he was showing the high burden of asthma in this young adult population. But once we moved to the right, the group was examining access to care for asthma across different age groups. And though we have a high burden in that young adult group, those who are accessing care is proportionately much less. So you see how the second bar from the left goes down. And why is this? So as I learned, there's a lot of stigma around asthma for young adults, specifically for many factors. And I really, if you have time to still check out his poster, if you haven't, it's very interesting. And of course, understanding this factor can help us understand why people are not accessing care and even improve our analyses when we try and look at asthma outcomes or other kind of data science tasks. Here's another example where we're looking at cardiovascular disease risk. So this is something we often want to look at much in the future, my risk of getting a heart attack or having a stroke. And there's many factors that can influence this. I just illustrated here a few of the individual level factors. Again, hypertension, smoking, BMI. And when we think about what data is being considered, this will also affect the decisions we're informing. So if I'm predicting my cardiovascular disease risk and say I have an increased risk, and I find from looking at feature importances that hypertension and BMI were, outside the normal range, that's a conclusion I could give, and maybe I would be prescribing pharmaceuticals to address that. But if I also considered the environment that I'm in, that maybe enables me to go on daily walks, to have that exercise, and I understand that also that's in relation to my CVD risk, that can change the decision that's made from the data and the analytic model. So what's a way to address this? The fact that we need to consider these broader factors, but of course they're very diverse, just like all of us. So here's one example I would share with you, which was generously supported by the NIH. Again, thank you so much. This is through a supplement to our DSSD training program. And what we've done as part of this supplement, which is looking at readying a lot of existing data sets for training on machine learning and AI, to look at this social determinant side, we've also formed this working group or community of practice. And you can check out our website through another QR code for you. And the idea here is that we'll both at the same time, we'll able to elevate good examples and projects to work on in terms of looking at those multi-level factors, and also create those important data resources. So the image is from was when we got together in the summer in Eldoret, and since then our group has also proceeded on a few projects in order to create some of those data resources. So what is our community of practice or working group doing? Well, first of all, we're addressing the fact that we know ideas can travel globally, and they do travel globally, but they take shape locally. So what does that look like on the ground? It also helps us create very useful data, because now we're able to ground all of the quantitative information in a qualitative understanding of what are the relevant factors, how are they categorized, how are they measured, and create more useful data and models. This group structure can also counter expertise inertia, as some like to put it, which is when people who have been, maybe formulating or working on some area for a longer time have more say in terms of how, in this case, measures are defined or captured. And this, we can also free up space to have new people who also may have less power join that conversation. Finally, as we know, data science is such a fast-moving space, it also provides an opportunity for all of us to keep learning and gain from each other. So what we consider data is very important, and partnerships can help shape that. It can shape the questions that can be asked based on what data is included. Partnership models that support exchange of global best practices, but foreground local innovation are important in data science. And as one example I shared with you today, we have our social determinant data community of practice. So a new twist on the old saying is what's computed depends on who's computing it. Okay, I look forward to hearing more from all of you. Thank you.
Yeah, thanks so much, Rumi. That was really a nice big picture view of how we define data and how that affects partnerships. Our next speaker is Bill Hirsch. Bill is a PI on the Computational Omics and Biomedical Informatics Program, or COBIP, training program. He's also a professor of medical informatics and clinical epidemiology in the School of Medicine at the Oregon Health and Science University. He's a leader and innovator in biomedical informatics education, doing research on issues such as the application of search techniques to electronic health records, aiming to improve patient cohort discovery and amplification of signals of rare diseases. And Bill today will be talking about international partnerships. So please join me in welcoming Bill to the stage.
Okay. Well, I also want to thank everyone for the opportunity to speak here and talk a little bit about our program. I'd like to give a few general comments to introduce the program, but since the focus of this session is on partnerships, I'll talk about that. So the XM, the MPI, we have two PIs, myself and Dr. Tanashi Mutsvangwa, who couldn't make it to the meeting this year. He was in Cape Town last year. And also Nikki Mulder, who you all know, is a co-investigator on the project. And Dr. Hossein Bandu is our combination project manager, teaching, programming, and data science topics, machine learning, and so forth. And so this is our main team. Just a little bit about let me just move over a little bit so I can see the slide. I won't read this whole thing, but Africa, like everywhere else in the world, is generating more health related data, omics data, clinical data, imaging data, and so forth. And so the goal is to train future researchers, professionals, and leaders in this area to be able to do things with this data, to put it to good use to improve human health, and in particular in an African context. So our program, just kind of the big picture, is a partnership between University of Cape Town and Oregon Health and Science University, which this time of year is 10 time zones away from here. Although fortunately I'm a morning person, so in fact I participate with many of you at like 6 a.m., even 5 a.m. meetings in my basement of my house. But the program aims to build a new graduate program in what we're now calling computational health informatics. And the partnership brings together complementary expertise. So UCT is very well known for its bioinformatics work, biomedical engineering, imaging and computation, and statistics. One area that is less developed at UCT is in this area of clinical informatics, that is informatics applied at the person level, patients, healthcare system, et cetera. And one of the strengths, which the grant reviewers must have thought was useful, is that the clinical informatics courses in my program at Oregon Health and Science University are pretty much all online. And we've had people from all over the world take courses from us. I know that some people in this room have taken various courses that we have offered. We also have expertise in clinical research informatics, and certainly expertise in data science, and also expertise in developing online courses. So our grant aims to build these new programs, but also another step, actually on my screen on my computer, that oval would be around the whole thing, but to actually try, once we develop the program, to try to export it to other areas of Africa. And we have a number of collaborators, and that's what I'm going to talk about for the rest of my talk. So I will again focus on our partnerships as I go through the specific aims of our project. So first, we want to develop this new interdisciplinary data science program. Like many programs, we've had some challenges getting up and running, but we're all ready to go now. We have applicants. We have over 50 applicants for our master's program. And again, one of the unique aspects will be that students in this program who are interested in the clinical side of data science will be able to take clinical informatics courses at OHSU, which is the acronym for our university. So just some partnership things, like many of the programs, we have a training advisory committee. So there are partners in giving us guidance and helping us with some of the admissions decisions, and recruiting trainees, which has not been limited to South Africa. And then a second aim is to train faculty in biomedical data science. So we have training activities aimed at faculty to help them develop the expertise, get up to speed on the new technologies and so forth. And in particular, this idea of exporting the program as it develops is a big part of this. And you see the countries listed on the right, where we have identified people who are interested in potentially exporting the program. And ironically, one of them, Dr. Tunga Sumbini, some of you may know from Zimbabwe, is actually a graduate of our master's program. He's also a physician. Anyways, this a group of 11 was brought together a few weeks ago in Cape Town. I participated in some of the meeting remotely, and we're both kind of talking about what the program will entail and doing some planning around what their needs were. And so on these slides, the things that are underlined are partnership activities, including on the previous slide. And we'll aim to replicate the curriculum at the other institutions, and then hoping to establish our program as an international center of excellence. Things like having a doctoral symposium that would be Pan-African, certainly collaborating with other institutions and having us well known. So just to show you some of our partnership activities, the slide on the left, you actually can see me in the middle. We did a dry run. We didn't anticipate any problems in delivering a course online. We use a lot of asynchronous learning, voice over PowerPoint, learning management system, and we do some things synchronously as well. Probably the main course that will be taken by students in this program is the Introduction to Biomedical Informatics course that I teach, that all of our graduate students take. And it's been offered in different ways. And again, I know there's at least a few people in this room that have taken the course. The program was not yet launched. So we basically opened it up to any student from UCT to take. And we got 7 takers, and they enrolled in the course. And then fortunately, right in the middle of the course, I happened to be in Cape Town for the final H3A BioNet meeting. So I got to meet them all in person, which actually is another part of online learning that I actually really enjoy, is meeting people in person. So these are the 7 students, and they all did very well in the course. They took the course for credit. They could transfer the credits from OHSU to UCT, and I know that most of them did. The second picture on the right is the workshop that was held a few weeks ago of the people from the countries listed on that previous slide. You also see Nikki there, and standing right next to her is Tanashi. And again, I participated for part of the meeting remotely, and starting to plan this partnership process where we can hopefully look at ways that in the long run we can export the program. So that's all I'm going to say. I didn't see any warnings there, so maybe I was under my time. So thanks.
Yeah, thanks so much, Bill, for showing us how you operationalize some of these principles of good partnership in training programs. Our next speaker is Amina Abubakar. Amina is one of the PIs on the Uzima DS program, and I'm trying to avoid using acronyms, so if you don't already know, Uzima is the utilizing health information for meaningful impact in East Africa through data science. Amina is also a full professor and director for the Institute for Human Development at Aga Khan University in Kenya. She is a senior research scientist at the Kenya Medical Research Institute, Wellcome Trust Research Program, and she has a visiting appointment at the University of Oxford in the Department of Psychiatry. She's trained as a developmental psychologist with almost 20 years of research experience in rural settings in Kenya. And today she's going to be talking to us about research partnerships in multicultural settings. So please join me in welcoming Amina to the stage.
He saw that I came from the rural areas, so he needs to give me proper instructions on technology. So I feel like I could just say what I want to say has been said by the first speaker. So I'll make mine short and talk a little bit about some of the highlights on issues. So most of my presentation actually will be informed by what is in this very nice commentary that took a lot of work to write. It's in Nature. If you have a chance, please have a look at it. And I also wanted to emphasize what was said earlier. Most of the time we are focusing on the global north, global south divide, but we have to realize that also south to south partnerships are important, but even within country partnership. So like Moi University, how do you interact with a smaller university like Turkana University? somewhere in the northern part of Kenya with hardly a quarter of the resources you have. So I think we need to keep an eye on that when we are thinking about issues of equity. So one of the things that is really outstanding is that when you think about inequity in research, there are really several layers of injustice. So what research has shown is that partners from the North in any collaboration will benefit more in terms of authorships, career progression, setting agenda, and who owns data and samples. I know now countries are putting in more rules, but that has been really a historical issue. But also, because of the way funding and credit is given, those who get more publications tend to get more money. And so there are few centers within Africa. I've put that as center of excellence because it depends on how we are looking at the metrics that will keep receiving more and more funds. And the problem is not just that this is an injustice on other parts of Africa not receiving funding, but it also brings to question the generalizability of the data we are having. If you look at certain systematic review, data from Africa would be coming from certain pockets within Africa, and other pockets, little islands like Comoros Island, will never have a publication. So we don't know what's happening in those parts of the world where we may actually need to know more about what is happening. But this is open science is a new push, but it's bringing new challenges. Data sharing, it takes forever to get data. If you work in certain parts of the world, you'll be stuck in the field. You will have a million of challenges to get your data, and you have a very tight time frame to do analysis and keep it out on open access. The problem with that approach, if African scientists don't have the right infrastructure, the right resources, and the right technical skills, is that then we become data collectors. We put the data out there for someone else to publish. But also, recently I was in a survey about open access, where journals in psychology were asking, if we give you 50% waiver, will more African scientists publish? I actually told them, you're asking the wrong person. I have funding from NIH, from Wellcome Trust, from DFG. There are people with no funding at all. 50% of $1,500 or $3,000 is $1,500. Where are they going to get that money? So if they don't get into these open access journals, their papers are less read, they are less cited, and therefore these are really layers of injustice for them. When we look at citations, downloads, and everything as metrics for performance and excellence. So what are the root causes to this? One is just funding. Who is funding science? 90% of it is coming from the global north. And I know a lot of effort is now being put into changing some of the way we fund. But because quite a lot of the money stayed again there in the north, the agenda setting was happening there, but also just differential access to resources. I have had the benefit of working, let's say, at Oxford for many years. I know when I need to put in a grant, I have a whole machine of people supporting that process. In other settings, you really don't have a grants person to support you. But there's also technical aspects and infrastructural aspects. Somebody raised this during the first day. We get 8% in direct costs. We can't really build infrastructure to do anything with 8%. I know, I'll give a very simple example here. We can't purchase, I think, computers from the current funding. I have to find money somewhere to buy computers because my institute doesn't have money to pay for it. So, but one thing I'm going to also focus on, I'm a cross-cultural psychologist. I had the benefit of moving from Kenya to Netherlands for my PhD. And the first thing my supervisor told me, the humility you are taught, it doesn't work here. Everyone here is pushing about how good they are. You sit here and tell us, we did this, I'm thinking maybe, said, no, that will not work. People doing half of the things you are doing are busy shouting on top of the roof about it. This is culture. You know, there are different communication styles, there are different leadership styles. I don't think one is better than the other. We just have to know they're different and acknowledge it and work within those contexts. But there's the metrics of success, language barriers. Quite a bit of Africa is not English speaking. English is almost the language of science. They are really disadvantaged. But even those of us who come from English speaking country, I still think in my mother tongue. Then write it in English, which means the grammar is bad. And you'll notice it in my PowerPoints. Just acknowledge that English is not my mother tongue. And it does affect how quickly you write. It affects output and productivity. I'm putting that in quotes. And we have to acknowledge those simple barriers that people face on a day-to-day issues. This is a nice, I can't go through all this because I know we have to save on time, but UKRI had a whole study carried out about some of the barriers to partnerships and effective and equitable collaborations. And you can see that there are quite a number that are actually systemic. For instance, the fact that research agenda at that time, I know recently they visited Kenya to try and discuss about the agenda, was just being set by UK academic institutions, but also just expectations about where data will be stored, expectations about who leads the program. And I think Anne said all that very well. But also weaknesses within partnerships where they're quite transactional and people sometimes have very, what is this called? The expectations they have for those in the field. Because unfortunately, most of our partnerships at the moment have not been a partnership whereby I'm a co-PI in a study where data is being collected in US or UK. So the data is always being collected in Africa. So the data collection process is heavy lifting. And people sometimes just do not fully appreciate the groundwork you've got to do to get that data out. So how do we address some of these issues? As a psychologist, the first thing in treatment is just to acknowledge and discuss. And I know this has been put out with by Anne. So just the fact that we are having a session on equitable partnership, for me, that's a first good step. And I think, as Anne said, we are moving away from equity to actually justice. You know, ensuring everyone has equal opportunities and equal tools to achieve the things they need to achieve. That's a very nice drawing from the Busara Center blog on data tools. So there is quite a lot of guidelines, and Anne went into really great details on them. So I'll just highlight one that the Research Fairness Initiative. And their guidelines, they've put them under three major subheadings: fairness in opportunities, you know, ensuring the agenda is set across different contexts, ensuring the available opportunities actually address the needs of people, so that you're not offering opportunities people don't actually need. It's not priority in that area, but also fairness in the process. When let's say, even if you say now, we would like partners in Africa to lead projects, but the requirements to submit that project is so difficult that I'm never going to be able to submit on time. How will that lead to equity? But also fairness in sharing benefits, costs, and outcome. For instance, even as we push for open science, how do we ensure that African collaborators, those with less resources, actually have the opportunity to use the data, you know, properly and feel like they benefit from it without blocking scientific discovery? So you don't want someone keeping data for 10 years, but what is the optimal amount of time? So I don't have time, but I can just quickly highlight some of the things we are doing. Open communication. I think we try to tell each other what we think as much as possible, respectfully, but nicely. We invest in relationships and cross learnings. We have set guidelines, written and unwritten, on outputs, and we try to co-design research ideas, because now we have gotten almost 3 new projects beyond Uzima, and we are really working towards co-designing research ideas. But more important, that is very close to my heart, although we are not a training program, we are a research program. One of the key things we put from the start is that our fellows, our PhD fellows, our research assistants, the team in Kenya will have the first go as first authors in publication. Now, this slows down. I have to be clear. This slows down publication because they need intense mentorship. But I think that is what we need to do to ensure equity. If we really just focus on very quick productivity, how many papers you're publishing, then you want people who are already there, which means we are not giving opportunities to others. So one of the big questions is, as DSI, what can we do as a consortium? One, we are so big, we should be role models. We need to, from this session, to think about, are we doing it right? Where can we do it better? But we also need, I think, the funders. I know this discussion was held in other funding institutions. How do we balance equity and excellence in selection of partners, in selection of pilot projects? Because if we are only going to say we are going to only fund those who are excellent in certain things, we are only going to fund certain pockets of Africa. And that, again, is not just, but accountability. Who holds us accountable for practices that are not collaborative, for practices that do not raise the status of our partners who have less resources? Thank you very much.
Thank you, Amina, for reminding us about many of these challenges to equity and partnerships, and also sharing some strategies from your experience. Our next speaker is Samuel Edie. Samuel is a co-investigator on the Madiva project, Multimorbidity in Africa, Digital Innovation, Visualization, and Application. Samuel is a research scientist and a data scientist at the African Population and Health Research Center, or APHRC, where he manages data science projects that employ machine and deep learning to address problems related to the multimorbidity of non-communicable diseases. His background's in biostatistics and mathematics, and today he's going to be sharing some experiences from the Madiva Research Hub on engaging with stakeholders. So please join me in welcoming Samuel.
Thank you for the introduction. I'm a bit nervous. You know what you have to do, right? Now we know those who are not here for the morning section. Okay, so I'm very privileged to be given this opportunity to present on behalf of the Madiva Research Hub. So I'm going to talk about our stakeholder engagement processes that we gone through for the Madiva project. So my outline is I'm going to give you a brief introduction to what the Madiva project is all about, and then who are our key stakeholders, what are some of the stakeholder engagement activities that we've carried out, what we hope to see in the future, and then briefly describe some approaches like the participatory design for the clinical dashboard, and then I'll make some final concluding remarks. Okay, so Madiva is a research hub under the DSI Consortium, and we all know what multimorbidity is. It's a situation where you have an individual with several multiple diseases. And usually the healthcare systems that we have in our various countries are not designed to manage some of these multiple conditions. So you have somebody going to the clinic on Wednesday for diabetes clinic, and the next time on Friday, the same person is visiting maybe the HIV, etc., etc. So the key questions that we want to see is how do we identify people who live with multiple disease, chronic conditions, whether they are diagnosed or undiagnosed. And then how do we support or provide timely information for clinicians to be able to ensure that they offer proper services to their patients. So the whole idea of the Madiva project is to integrate several data sources, that is data coming from population and surveillance study sites for different surveys that are conducted in these sites, health facility data, genomic data, etc. And the idea is, can we design analytic tools that will strengthen patients' records and data systems that serves this primary healthcare? So this is the organogram for the Madiva projects. So we have two main sites, one in Agincourt in South Africa, and then in Nairobi, that is the APHRC site in Kenya. We also have other partners involved in this project. We have the IBM, Supreme, and then SBNMB at the Wits University. And the whole Madiva has two main projects. So we have the project one, which aims to develop and integrate data integration and visualization. The second project is focusing on precision public health. We have the DMARC team that is putting all this data together. We also have other, the administrative core, as well as the training core that offers internal training to our research team and postdocs. Yeah, so so I'm just going to highlight on the first project, the project one, which deals with the clinical dashboards. So this project has three main objectives, as you can see there. So we want to get this data together. We want to analyze this data and also involve stakeholders in the development of dashboards. So the main focus for this presentation is on the last objective, that is how do we support these health facilities in terms of building a service dashboard for the clinicians. We also have the component of developing a dashboard for researchers, but that is not the talk for today. So the whole idea about stakeholder engagement is that we are approaching this in trying to ensure that these dashboards that we develop actually meet the needs and the requirements of these key stakeholders. And this would help to promote a sense of ownership and a collective responsibility for these partners. Here are our key stakeholders. So in Nairobi, in the Kenya sites, we are engaging with the Ministry of Health, the national NCD units. We also work at the county levels where we engage the Nairobi Metropolitan Service. They have now transferred their mandates to the Nairobi County government. We are working at the county health management units. We also have the sub-county health management units that we work with. We are also working with health facility administrators and healthcare professionals like the doctors, nurses, and health record officers. On the other side in South Africa, we are working on the Agincourt sites where we work mainly with the Mpumalanga Province Department of Health, districts health departments, and then also the same, the health facility administrators, the healthcare providers, and then some community partners and patient groups. So far, how have we approached our engagements? So during the proposal developments, we engage some of these the government people in the protocols, in the grant applications. But once we got the funds, it was important that even through the ethical approval processes, we engage these partners. So we have, during the internal and external protocol approvals, we identify a focal person from the county who was a co-investigator for this project. And then we also the team paid a facility visits at the two sites to try to understand what the specific needs and challenges that these health facilities do have, and then the experiences that they are also currently facing in terms of how their data systems, how they use their data system to support decision making. During our inception and other engagement activities, we have taken advantage of those meetings to try to explain the purpose and objectives of the Madiva projects, and especially the dashboard components of the project to them, and to also understand their interests and whether whatever we are proposing actually aligns with their interests. Aside that, we've also had, getting into the development of the dashboards, we've approached this through a participatory design workshops, where we convene all the stakeholders in one place, both in South Africa and then also in Nairobi. Here we engage the stakeholders in the designing of the dashboard. And this workshop enabled us to gather insights and the various requirements that they need for the dashboards. The feedbacks that we get from these workshops, we are incorporating into the design of the workshops that we are proposing. And we have developed what we call wireframes, which are not the actual dashboards, but like images on how the dashboards will look like when you click here, what happens, and things like that. And this we are doing to make sure that the efforts that we are putting in place aligned with the expectations and then also the requirements of these various stakeholders. We are now at a stage where we are refining the wireframes, and then our next step would be to organize another workshop to continuously seek their feedback. So we show them these wireframes and then seek more feedbacks that would help us to refine the wireframes for these dashboards. And then we would proceed with, once we have gathered enough information, we are able to develop, test, and validate these dashboards. Obviously through, again, involvement with these stakeholders in the testing and the validation process, and then also make sure that these dashboards actually meet their needs and also are user-friendly for them to be able to use. And then we also plan to offer training support to them on how to effectively use these dashboards and how to increase adoption to ensure that they actually benefit from these dashboards. These dashboards will continue to evolve and adapt by seeking regular feedbacks from them and see how these feedbacks would go back to refine the dashboards based on their needs. So here are some images of what we found during some of these workshops. So you would find, so the first picture or image is how the data is actually captured in the health facilities. But the one at the top is how the data is stored. So it's not those nice, data in Excel files that you just get your hands with and just plug into your algorithms and start running your AI. In reality, this is how things are happening. And these other images are the workshops that we had. So you see the team meeting together, arguing and deciding on what's the dashboard requirements and the needs and their needs for the dashboards at all the levels of the health facility. And then once we are done, we ask them to present how they would want to, what they would want to see in their dashboard. So you see an image. So we have a flip chart where they draw and then indicate whether they want this data to be reported weekly or daily or whatever ways they want this data to be represented. Okay, so I have warnings. So let me just go quickly to my concluding remarks, some of the lessons that we have learned. So we have understood that, fostering a collaborative environment is very important. This encourages open communication with these stakeholders, and also to make sure that these dashboards that we design aligns with their strategic goals and priorities. We also hope to promote actually open, promote transparency and accountability by making sure that we communicate clearly the purpose, the features, and the data, where the data sources will be coming for these dashboards. We also prioritize, these questions usually come up when we meet them on how do we ensure that the data they are providing how do we secure them, and what are the privacy concerns? And we've often assured these stakeholders of the data security and confidentiality measures that we have put in place. Because we are working in 2 sites, I mean, the dashboard designs needs to also be adopted because we have had separate workshops, these participatory workshops. And so we've come to understand that this dashboard needs to be designed in such a way that it reflects the unique characteristic of each local context. And then there are also other things that we have done, especially in terms of the different roles and needs within the health facilities. We would see that maybe sometimes the medical doctors says they need a dashboard. The health record officers also needs the dashboard. So we also decided to make sure that we set very realistic expectations with these stakeholders in terms of what are our limitations, what are the constraints, and then the timelines, especially in the development of the dashboard, so that we don't raise so higher expectations. Also, we also want to make sure that these dashboards that we develop are scalable and interoperable with the current systems in terms of how data gets fed into the dashboards and how this system integrates with other existing systems within the dashboard, within the health facilities. And then we also would continue to offer open channels to that helps to offer continuous support even at the, when this project is ended. How do we maintain? How do they maintain these dashboards? How do they update, and how do we offer support to these stakeholders? So I think my time is up. Thank you very much for your time and your attention.
Thank you, Samuel, for giving us a nice view of how Madiva approaches these engagements with stakeholders and how the principles of partnerships fit in. Our last speaker for the DSI Africa projects is Shaniqua Callier. She is a co-investigator on the Bridging Gaps in the LC of Data Science Health Research in Nigeria, the Bridge LC program. She's also Associate Professor of Clinical Research and Leadership at the George Washington University School of Medicine and Health Sciences, where she teaches and lectures on health research ethics and genomics law and policy. She has a background in healthcare law, international health research ethics policies, and human genetics laws and guidelines. And today she's going to be talking to us about the Bridge LC experience in engaging Islamic perspectives in data science health research in Nigeria. So please join me in welcoming Shaniqua to the stage.
Good afternoon. It's a real privilege to be here and to follow so many important presentations. I know it's the last presentation of the day, and it's just great to see all of you here because I think this session is just so important. So briefly, I will provide background and an update on Bridge LC, and then focus on partnership-related topics. I will discuss why we examined Islamic perspectives and resources and principles, and describe our team's research findings so far regarding Islamic principles. Lastly, and this is a topic for group discussion, please consider whether, why, and how cultural and religious perspectives should be incorporated into data science health research ethics frameworks. So that was my agenda. Bridge LC is an interdisciplinary research ethics study. It's led by Dr. Temidayo Ogunduran from the Center for Bioethics and Research in Nigeria, and Dr. Clement Adebamowo at the University of Maryland. It's also a training project, and its objective is to identify gaps in Nigeria's existing health research governance frameworks that could weaken the ethical oversight of data science health research in the country. To do this, we are evaluating laws, policies, and perspectives systematically and empirically to inform an improved governance framework responsive to the ethical, legal, and social implications of data science health research in Nigeria. Our methodology involves expert informant interviews, surveys, and a modified Delphi process to engage experts. So first, why are we incorporating Islamic perspectives? Isn't it enough, you might ask, that ethics review committees should consider benefits and harms for communities and groups? Those of us who work in medicine see how customs and beliefs play out in medical care, especially when there is an ethical dilemma. Research projects and new technologies also raise ethical dilemmas and require communication, education, and trust building. My colleagues and co-panelists explain that. Islam forms the second largest religious affiliation across the world, and very little study has been done to explore its role in the context of research ethics. In Nigeria, Muslims comprise close to 50% of the population or more, and indigenous religions make up the minority. As various groups have debated Nigeria's development, politics, and identity, Nigeria's religious diversity has been a source of cooperation in some senses and a conflict in other contexts. For these reasons, my colleagues in Nigeria have considered the Muslim population in ethics work in the past, and we continue to do so in this project. Second, bioethics generally has a Western focus. Although bioethics is not inherently religious, scholars link many foundational principles to Christianity. Today, there are criticisms that bioethics has performed inadequately on issues of justice with respect to marginalized groups. Third, while the broader bioethics field has developed secular approaches to care and to research, one of the authors I'm going to cite later, Dr. Padella, points out that despite incorporating various philosophical traditions in Islamic context, ethics maintains a religious view and takes inspiration primarily from religious texts. Fourth, inclusive approaches may help improve trust. Here is an example from our Bridge LC colleague, Dr. Jegede. In 2003, 3 states in Nigeria boycotted the polio immunization campaign. At the time, Nigeria accounted for 45% of polio cases worldwide. The 1996 Pfizer trials in Kano, political party leader opponents, so politics played a role, and also religious leaders played a role in the boycott. While some Islamic leaders supported the efforts, others effectively discouraged it in their local areas by spreading the belief that Western outsiders likely contaminated the vaccine with HIV or agents that cause infertility or cancer. Now, arguing the opposite, other Islamic scholars warned that these beliefs distorted the image of Islam by making it appear as if it contradicts science and medical progress. Dr. Jegede describes a complex group of players and socio-political conditions. For example, American political conflicts with Muslim countries overseas impeded buy-in into what was seen as a Western vaccine. Dr. Jegede explains that Nigeria eventually overcame these differences by holding meetings that were inclusive of diverse Muslim leaders and acting on those leaders' major concerns. For instance, one meeting led to a consensus to test the vaccine samples independently in a Muslim country. And after being satisfied with the quality and production process of the polio vaccine, more Muslim leaders became supportive of the campaign efforts. So a lesson from this article, or what Dr. Jegede tries to convey, is that engagement with diverse religious leaders helped improve vaccine uptake. What I want to ask you, this is something we could possibly discuss later, is would you consider that a partnership? How are we defining partnership? Is this an adequate partnership? What other partnerships could help advance the uptake of data science health research projects and policies? Next, I'll discuss our research process. Chris Armina, a former pre-doctoral trainee in our program, is one of the collaborators. He's continuing to work on this project. He served in the military as an Arabic linguist and translator and studied international and foreign law. Chris identified topics in the Quran relevant to this discussion, such as privacy. The Quran is the holy scripture of Islam, believed by Muslims to be a revelation from God. Islamic scholars interpret the Quran using various sources, such as religious texts, legal edicts, and scholarship. The process of interpretation and analysis is nuanced, requiring an understanding of Arabic, Islamic history, and context. And to be frank, this is a developing area for me. My team members based in Nigeria have much more experience in this area, and Chris cannot be here today because he's a practicing attorney now in New York. Our team is also reviewing published literature on Islam related to bioethics, technology, and health research. Here are just 3 examples that are readily available in a book search. Suleiman examines the values and virtues found in Islamic tradition that Muslim biomedical researchers encounter. Suleiman explains that moral reasoning involves intuition, reason, and revelation, and different Muslim schools of thought have varying theological beliefs resulting from each. A significant aspect of Islamic history is the establishment of Sunni and Shiite schools of law, which interpret the Quran differently. Nigeria has diverse Islamic communities. The majority of Muslims in Nigeria follow the Sunni branch of Islam and belong to the Maliki school of thought. It is also home to a significant Shiite minority and several other notable groups. The book in the middle, Islamic Perspectives, reports on a seminar held in 2013 that convened scholars of Islamic background, biomedical scientists, and Western bioethicists. They discussed principle-based bioethics, the role of religion in bioethical reasoning, specifically from an Islamic perspective, and the concept of, or the idea that there could be universal principles for bioethics that might or might not involve religion. So that was a discussion for debate. And the last book, and again, these are just examples, there are many more. The Right to Life, Security, Privacy, and Ownership in Islam explores the ideas of human rights that intersect with medical ethics according to the laws of Islam, such as the sanctity of life, abortion, suicide, and euthanasia. We also identified articles that focused on theories about an Islamic approach to bioethics. Authors describe Islamic bioethics as a growing field where Islamic principles can inform bioethics, not necessarily a field that separates Islamic bioethics or thought from bioethics, but to inform, to help improve and enrich the discussion. Notably, they argue that it does not have a cohesive framework. As in the polio vaccine example, there are going to be different scholars who support technologies based on certain theories and who reject technologies, possibly even arguing about the same theories, but in different ways. A recurring point, though, was the importance of bidirectional learning to ensure that all users of a bioethics framework, regardless of religion or position, learn about the benefits of a technology and also have a chance to discuss how it could be perceived in the diverse communities that are being served. While it remains to be seen whether there will ever be a cohesive framework or whether that's even possible, strategic partnerships may help researchers and institutions better navigate differences in belief systems and communicate to the public. A major challenge identified in the literature is that different Islamic schools of thought and jurists prioritize different objectives and principles. Dr. Padella, for instance, took issue with another scholar who prioritized faith, progeny, wealth, and intellect, but excluded honor and other objectives. He argued that the author bypassed the diversity of existing principles by drawing on one model framework. So a question for our team might be, while many Nigerian Muslims follow the thought of Maliki, does that mean DSHR policies and frameworks should also prioritize the same principles? How do we prioritize how we think about different objectives and principles when we're developing frameworks, when we're advising research ethics committees, and also thinking about the impacts on individuals, families, or communities? Let's turn back to privacy that our pre-doc Chris examined. The Quran has language clearly relevant to the topic. It prohibits opening private correspondence, espionage or spying, and unwarranted suspicion by others and the government. Professor Kamali, one of the authors I cited earlier, argues that an individual's or group's private life should not be monitored by either the state or society, even if it is for a good cause, but explains that the Quran allows for exceptions for the public good. So how might this apply to DSHR, data science health research? What about a health research proposal to use voice, audio, and GPS tracking? Could such a study be permissible in the eyes of those who make decisions based on their faith if it tracks the whereabouts of bystanders in close relationship with the research participant? Should a national ethics code require religious and community leaders to analyze such questions as ethics review committee members? Reaching the conclusion, I know that was a brief overview. Bridge LC's next steps are to synthesize the normative literature we've identified relevant to DSHR and conduct a systematic literature review of how ethical principles are implemented in data science health research, engaging Muslim countries and communities. I hope our discussion today will be ongoing. You might further consider why and how should cultural and religious perspectives be incorporated into local DSHR ethics frameworks? And importantly, what opportunities for partnership and collaboration exist on the topic of religious and cultural diversity within the consortium? I look forward to hearing from others. In the meantime, I would like to acknowledge the Bridge LC team that is doing this comprehensive work and training in Nigeria. Thank you.
Thank you so much, Shaniqua, for a great presentation and helping us think about how religion and ethics and health research all intersect. I'd like to invite all of our panelists back to the stage, and we're going to get started with some Q&A. So while everyone makes their way to the stage and you start thinking about your questions, I just wanted to send regrets from my colleague, Tiffany Lash from the National Institute on Biomedical Imaging and Bioengineering. She couldn't make the trip in the end, but I also want to thank Carrie and Eileen for helping out, keeping us on time. We're doing really well on time, so we have plenty of time for questions. And yeah, if you have a question, feel free to raise your hand and we'll get a microphone to you.
Hi there. This is a question for Dr. Amina Abubakar. She talked about trust and openness. So I was just wondering, Dr. Abubakar, do you like your Uzima Global North partners? And have they ever made you mad? How to wake people up?
It's the great button.
Thank you. So interestingly, I come from a family of 12 and I'm 11th born. So I've learned to fight for my space. So it's not a question of liking, it's a question of learning to negotiate. And I give that in tip to all my students. Learn to negotiate for your space. Thank you.
I also have a question for Dr. Abubakar. You raised the issue of high journal fee, open access fees. I think it's an issue for people even who have NIH funding. I really resent having to pay for a journal article where we're paying well over the cost of a stipend for a PhD student. And I wonder whether it's not something we as a consortium should try to do collectively if we engage with publishers. If we look at having a policy which says we won't submit to journals that have fees above a certain amount, because I think, of course, we realize there are real costs in this process, but I think some of the fees are just outrageous.
Thank you. I think academics must be the only people who provide a product, review it for free, and still pay for it to be published. I'm really not sure what we are doing wrong, but we need to advocate strongly against all this. What I would feel sometimes is really exploitation by publishers. But yeah, I think such a big consortium with such a huge investment and a lot of outputs to come out, we really have the power to push back on some of these issues.
Would anyone else on the panel like to comment?
Yeah, I mean, this is an interesting question. Part of my research involves disseminating knowledge-based information to clinical people, and it's almost, I think, like an unintended consequence that we always dismayed having to sign away the copyright to our articles, and then we have a new method now, open access, and author pays. But it's clear that there's limitations to that approach as well. And, I guess really the ultimate challenge is, who's going to pay to disseminate research. I mean, fortunately, NIH, although I know not everyone is NIH funded, but it is an allowable expense on a grant for publication fees. But yeah, this is probably a problem we need to solve to keep equity in publishing.
Was another, oh, go ahead.
Thank you very much. Okay, hello. Thank you very much for the very interesting presentations. I'm really interested to know something from Dr. Shaunekwa. Sorry if I don't pronounce your name. It's a very fascinating kind of research related to health, but I wanted to know something from you personally. In your team, I saw you had a very big team in Nigeria. I'm wondering if there was any Muslim in the team, and if they were, how did they feel during the research in terms of finding themselves there? And if they were not Muslims, how do you feel like not being in the shoes of Muslim, trying to look at this, and you navigating somebody living in Nigeria and having to live with this kind of reality? Thank you.
That's a great question. Thank you very much for it. I feel very limited individually and personally to be able to do this work, which is why partnership is so important. The team is very large and diverse. A very small group of us are focusing on this particular project. Again, it's led by Chris Armina, who has experience working in Muslim communities, but a big part of our research is also interviewing people who are scholars in diverse fields with Islamic backgrounds and expertise, surveying the same, and also including Islamic scholars in our Delphi process. But I posed the question to how there can be more within consortium engagement on this topic as well, because this is a very large community globally and in Africa, and diverse perspectives must be considered thoroughly and adequately. And so that's going to require partnership. The question is, what does that look like?
I'm Charles Michelo from Across Research in Zambia. My question, I think it's also Dr. Mange and Dr. Abubakar, but probably Fogati could comment too. I have heard various aspects, but one of them was that sometimes in this collaboration, there are injustices. And in fact, even some of the solutions that were being proposed was more towards justice. I didn't hear elaborate ways of how to deal with those injustices. Dr. Mange, Dr. Abubakar, from your experience, and probably maybe the DSI network might not be the best example because there was an intention to create consortia, but even from the other collaborations where the intention to collaborate was not put, what mechanisms were or have been put in place, or from your experience, to deal with the injustices? But probably from the funding point of view, what appeals mechanisms exist from the funding agencies? I note even in football, there's an ethics committee that deals with those. Do we have such? Thank you.
Yeah, thank you for that important question around how we are dealing with, because I think it's not I don't think we have found the final solution to the problem. But I think, as I highlighted, I think there are issues to do with ensuring that the opportunities
are there for us to be able to deal with some of those injustices. And I think that's why we are all here, because I think from this consortium, I think the South-South is what is actually being put in place so to ensure there are opportunities in the South. Like, for example, this opportunity whereby we can have the main PI being from the South, because I think that's one avenue that has been very limited previously, because I think that is this one starting point. In addition to that, I think also from, as you said, even from the IRBs, empowering them so that they can be able to look at those injustices, even when they are reviewing the proposals within our own settings. So I think, for me, I think that is our starting point, but I must say we are still on a journey to achieving that.
Thank you. Just to add to what she has said, I think we need to address these issues from different angles, because there are very many layers to it. For instance, at individual level, I would say, like, when PhDs, masters, when we are training our students and mentoring them, we need to really empower them to be able to have the confidence to negotiate for equitable partnerships. Because I think that sometimes is lacking. I have seen this a lot where people really do not negotiate upfront. The other thing is at institutional level. We need to strengthen the research environment for institutions that have less resources, so that people can actually get the right support to review the grants agreements, to review data sharing agreements, so that they can actually sign off things that are equitable and not exploitative. And of course, IRBs also have a gatekeeping where they can look at this, is this ethical, is this equitable? But also I feel funders have a lot of power in ensuring equity by holding people accountable. How are you doing your research? Have you, we've been funding you for the last 20 years. You've been building capacity. Where is this capacity? So funders can hold people accountable. Funders can ensure that calls that go out people have had opportunities from different contexts to contribute to the priorities, to contribute to how it's being submitted. But also in terms of publishers, I know right now publishers are doing quite a bit of pushback. Previously, data from Nigeria would be published without a single Nigerian institution being funded or acknowledged or being an author. But I know now publishers are pushing back, and I think this will help. So I feel we need at different layers for each of us to play a role in ensuring there is equity and accountability in the way we do research. Thank you.
I did want to see if anyone from Fogarty or NIH might want to comment, or I think the broader issues of systemic injustice are very difficult, but there are ways to deal with harassment issues and things like that that do come up on a more individual level. Laura, or would you want to say anything about this? Sorry to put you on the spot.
Yeah, I would just add, I think from Fogarty's perspective, when we're developing funding opportunities, we do try to work some of these partnership and equity issues into our language and in instructions to applicants. In addition, just to refer to Dr. Peter Kilmark's talk from the opening session, we now do have an NIH Global Health Research Equity Working Group at NIH that is also exploring other ways that I think NIH can take action to make our funding more equitable. Thanks.
Yeah, is there another?
Just to add to what Laura said, actually, individual institutes and ICs are also building their own equity programs. So it is being addressed, but perhaps slowly.
Thank you, Sudha. Oh, go
ahead. Thank you, everyone. My question is for Dr. Smith, my nervous friend. You mentioned something about participatory approach in engaging stakeholders when you design your dashboards. I just wanted to learn from you because in my experience, our stakeholders are very difficult. They don't have time to do such kinds of things, especially in the design aspect. So how did you engage them, or how did you encourage them to involve in this design of dashboards? Thank you.
Yeah, thank you for the question. It's very important. So what we have done, especially for Nairobi, was the initial stage, that is getting somebody within their team to be part of the process. And in terms of getting them involved, mostly it's this focal person who has been doing most of the work. And then we meet them and have this engagement. So I think getting them involved and making it not imposing the ideas that we have on them, but letting them come up with what they really need has really been helpful. And I think that is what has really worked for us. In terms of their level of engagement, it has been wonderful. I mean, if you get into the group discussions, you find that there is so much enthusiasm in the way they want, the desire to have such a system that would help facilitate the kind of work that they do. Yeah, thank you.
Thank you. I want to do a follow-up with Dr. Samuel Eddy with regards to the dashboards. Different health facilities, especially in Nairobi, have different EMRs or EHRs in different cases. So I would just wish to that you elaborate on how the different EHRs feed into your dashboard. How do you sort out the interoperability issues with the dashboards?
Yeah, thank you. That's also another good question. So in terms of, so what we did initially was to conduct a data system audit at these, the two sites. So we had private hospitals and public hospitals involved in the process and assess the system. What we noticed was that in the government institutions, especially in the areas that we were doing this work, they do not have these EMR systems. So you saw in the image the picture of how they record the data and how the data is stored. So what they do is that they record them in these hard copies, and then at the end of the day, they would aggregate the results, and then they feed it into the national system that it's used for reporting to the different levels. But at the health facilities, they do not have system to capture data, especially at the individual level. And this is some of the areas that throughout the engagement, they seems to be welcoming the idea of having a dashboard to be able to help them capture this data and not go through these routine manual calculations to be able to feed into the system. So we are working with the programmer to see how this system can be interoperable, probably maybe developing an API that maybe we can connect to these reporting systems that are available. We've also engaging with one of the seed pilot projects that is developing a system that we are also looking at to see whether that system is developed based on the it's the global good products, which have a standard for the way health system data is being captured. And so maybe if that system also comes on board, we would see how we can use that system together with our system to help with interoperability issues. Thank you.
Would you mind standing up just for that camera?
All right, thank you very much. My question is for Bill Hirsch with the GoBIP training program. And I'd like you just to elaborate on how you decided on your partners. You said that you identified partners across Africa. And I think for a lot of people who want to get into partnerships with organizations like yours and training programs like yours, what was the criteria? How did you go about finding these suitable partners, and how can those wanting to develop in this area think about what they need to do to partner with organizations like yours? Thanks.
Yeah, I mean, I'd like to say that it was very, deliberate and thoughtful, but in reality, I think that most of the partners we identified were known to, actually the original PI, the grant has left the program, but he had a number of contacts. Others of us have other contacts. It is kind of haphazard, and there's probably better approaches to do that. But hopefully through this consortium and others, we can identify people and institutions whose interests and goals are aligned with ours. So I wish I could say it was more deliberate.
Go ahead, Peter, first, and then.
Okay. Thanks, Amit. I just wanted to comment on, I guess, on behalf of NIH and Fogarty. And first of all, it's just been terrific to be here. This is my first time to be able to come in person to the DSI Africa meeting. And I'm just so encouraged by what I'm seeing and very cognizant of what the opportunities are and also what the challenges are, just in terms of all the data, the infrastructure issues, the aligning the different data sets, all of the legal and ethical issues. So I know it's not incredibly rapid progress, but I realize this is going to take years to get these issues sorted out. So very happy to see that, and especially happy to see this panel, this closing panel on these important issues about equity. And we talk in the U.S. about being concerned that the data that we're getting for artificial intelligence and machine learning aren't capturing all the populations in the U.S. And every time I say that's, at least as much of an issue globally. So it's so important to have this project going on. So specifically about some of the equity and North-South partnership issues I mentioned on in my opening remarks on Monday, that we did have that, we do have the NIH working group. We had the requests for information. We had 186 responses. Really important to have that high response rate that we can say at NIH, look how important this is. Look at how much the community cares about this. And we have this working group that now has 9 of the institutes and centers that are most active working internationally. And really, I think even among the different institutes at NIH, comparing notes, what language are you putting in your NOFOs that we can put into our NOFOs, our notices of funding announcement that have these, that say, we're looking at this, we want you to see in your application that you're addressing these equitable partnerships issues. And just to mention, I didn't have time in my presentation on Monday, something that I'm really excited about late in the fiscal year last year. So this past summer, we had some additional funding for health disparities, and we had a notice of special interest and funding supplements for any of our training programs around the world. We said, if you can identify trainees who are members of groups that are underrepresented as researchers in your country, we can provide supplemental funding for those trainees. And we didn't know, is this just some American concept about diversity and equity and inclusion and accessibility? We were very pleased. There was a very strong response, and we have new trainees across basically all of our training programs in infectious diseases and HIV and non-communicable diseases, et cetera, from every region, from Asia, from Africa, from Latin America. So we've got Quechua speakers from Peru being added as trainees, and Turkana pastoralists from Kenya getting training, men who have sex with men in South Africa, Muslim women in Malaysia, et cetera, being added in as researchers, and really pleased about the potential impact. And we'll see how that goes. And if it goes well, hope to continue it. So stay tuned. But it very much aligns with the kind of work that you're doing of really having those voices, not just as participants, but also as researchers as part of the process.
Thank you. I think we have one more question just behind you.
To Dr. Samuel, I'm just curious and I wanted to find out. I think dashboard is one of the good things I think that people need in terms of capturing the information and then reporting it. But my question to you is, at the point of your engagement, knowing very well that there is district, province, and the national level, at what point do you engage with those individual hospitals? Knowing very well that your plan and your intention is to build a APS that will integrate the dashboard that you are building to the existing system. Has there been any standardization across all board, or you are just building it based on what the facilities or the individuals users need? Just to be sure of that. Thank you.
Yes, thank you. Like I mentioned in my presentation, we've engaged people from the top, that is at the ministry level, up to the health facility level. And in some of the participatory workshops that we've had, we've actually had representations from all of these different levels. And so we also get to understand from the different levels what their requirements are, what they need. In Nairobi, in Kenya, I know there is, they are currently developing a system that they want to use across board, but this is something that is still in the process. And we are not sure yet when that system would be rolled out. And even for them, they are not able to tell. But what we got to understand is that this is a priority area that is needed for them, especially at the health facility, so that they can report their data well, timely, and then also accurately, so that those are the higher levels will be able to get this data to report and to inform their policies and decision making. Thank you.
So I'd like to pose one more question starting with you, Rumi, and then anyone else who wants to jump in. What's your advice to this community, your peers, the coordinating center? What's your advice on how to make sure partnerships are equitable? What else should we be doing? NIH, the coordinating center, but also this community of peers. What would you like to offer?
Thanks, Amit. I think it's a great question. I wouldn't ask me. I'm based at NYU. Probably I would, that's my advice, but happy to hear what others think as well.
Shaniqua, go ahead.
That's a great question. I think I might start next time with this panel and start contextualizing our conversations about the scientific issues that are being experienced within the context of equity and justice. I think there were some statements related to ethics and inclusion and community engagement that I actually disagreed with yesterday. And I think that those statements might have come from people who aren't as experienced working in ethics spaces. And having this kind of a conversation earlier could set the stage for some common understanding about what's appropriate when engaging communities. And if there are questions, if there's debate, that's fine. But I think these conversations should actually come earlier.
Would anyone else like to comment? I know some of you already answered in your presentations too about some things that we can do. Well, we have one more person coming up to speak to kind of wrap things up, but let's give our panel a round of applause. And you can stay here. It'll be a short wrap up. If you, I'd like to invite the new co-chair for the Partnerships and Outreach Working Group, Aliki Edgecombe. She's part affiliated with the DSI Africa Law Project, the LC Project, and she's also a lecturer in the School of Law at UKZN, and she's going to help us tie this all together. Round of applause to welcome.
I don't think that's an easy task to end off this conversation, but I think what we can agree is that we've raised very, very complex issues here today. I think sometimes we can oversimplify partnerships. And when we're in this kind of setting, we're trying to say, okay, we need to partner. And actually, there are real practical hindrances to doing that, both from a data perspective, how people feel about the data they've collected, community engagement as well, religious group engagement. These are all complex issues that I don't think can be really adequately dealt with or covered today. I mean, this is really the start of what needs to be an ongoing conversation. And I think that probably that comment of this is probably where the, these kinds of conversations, these consortium meetings need to start, is perhaps a fair one. But to tie it all together, and I think that the major thing that came through very, very strongly is that we cannot do this without partnerships. And I think we all know that to be true, but that to be able to achieve that in an equitable way is not an easy task. It's messy. And I think that we have to accept that in this kind of research that we're doing, and while we're trying to engage partners that may not necessarily think the same way that we do, have data sets that need to be cleaned up in a certain way, may not have the same capabilities, whatever it is, that it is going to be messy and requires constant communication, constant careful thinking, constant engagement with the communities and with other researchers. So I think that this was perhaps a good way that we should have started, but actually an excellent way to end, because sometimes we remember the message at the end a lot better, and something that we need to take home and really ponder on and continue these conversations in our meetings going forward. So thank you to all our panelists for their time and their sharing their experiences with us and their expertise. And let's continue to engage with them this evening. Thank you very much to everyone who's attended this session. Thank you.
So can we have Laura, would you join us? And Shenfing? So we're going to hear from David, Shenfing, and then Laura, and then myself.
Yeah, thank you, Michelle. Good afternoon once again. It has been a long time since Monday, others since Friday. All of us being here and then other activities around here concerning our DSI Africa Consortium meeting. And now we are coming towards the end. First of all, I want to thank everyone that has participated in this wonderful meeting. It has been an opportunity to meet, see each other, interact, discuss, but also put forward important resolutions and suggestions. And I trust we are going to put them into use and in implementation where possible. And I think if all of us say that what we have discussed and found important to take forward are going to be possible. Why are they going to be possible? We are experts. We have good support from NIH and others. And with that willingness, I think what we have seen, what we have suggested, what we have put forward is going to be possible. And that is only going to happen if all of us agree that it's going to be possible and work towards possibility. Thank you. Second thing, I want to thank everyone that supported this meeting in terms of most of you were presenters, presenting good topics, inspiring ideas and suggestions. And also I want to thank the moderators, the facilitators who facilitated all the sessions that went on well. And here we are concluding our meeting as, to me, as a successful meeting. And for sure, we appreciate and we thank you for the efforts that you provided. Thirdly, and most importantly, I want to appreciate and thank our supporters, our funders, NIH, FOGAT International. Thank you very much. We are here because of your support. We are here because you are behind us and trying to make us proud of doing data science for health that will improve the lives of our communities through providing appropriate and evidence-based healthcare services. Thank you very much. By the way, NIH and FOGAT International, they are not only funders, they are even advisors, supporters in all ways. You have seen them here, still standing with us or everywhere. So to me, they are not only funders, but they are supporters in all ways. For sure, we appreciate your support and we value it. Last but not least on this note, I want to take this opportunity as the chairperson of the steering committee again, and on behalf of the steering committee members, and maybe on behalf of all of you as participants, to thank the coordinating center led by Michelle and the rest of the team for the wonderful job and work that they have done. Please give them a round of applause. Yeah, for sure they are doing great job, well coordinated, good work, and I think we have seen how this meeting has gone. It is well organized, good logistics. For me personally, I have appreciated, but also on behalf of the steering committee, we have appreciated. Thank you very much. Now, again, let me take this opportunity as the chair of the steering committee. We are looking for someone from amongst ourselves, from you, to be a co-chair, so that as I step down, as I end my mandate, I think this Feb or January. Oh, now. Oh, okay. I thought I had 1 or 2 more months to serve, but anyway, this is the best. This is the best. Oh, wow. So we've been looking for someone to be a co-chair to support. My co-chair now is going to be a chair. And fortunately, first of all, I want to thank you all who voted. First of all, you nominated and then voted. And I want to thank all those firsts who were nominated and accepted the nominations. We had 4 nominees. Of course, we are looking for 1 co-chair. And finally, we have got the co-chair with the majority of the votes. So among all the projects, there are some who didn't vote, but at least 60% of the projects voted. And according to the votes, that is out of 24, we have someone who have come out as leading with the votes with 13 out of 24 that make 54%. The rest of the 3, one have 3 out of 24, another one 2 out of 24, another one 3 out of 24. So with this percentage, with this vote, we are taking the one with the highest, that is 54%, 13 out of 24. And let me take opportunity to announce this person. And if I announce, he or she should come forward for recognition and congratulations. And this is none other than Joyce Nakatumba Nabenda. Joyce, please come forward. I think we've been, we wanted someone from the other side of the gender, and now we are getting to the justice. Thank you very much. Congratulations. You come here to join us. Okay. So with that, I think allow me to conclude from here with good news of getting a co-chair and leaving my steering committee and the rest of the team in good hands. Thank you, and thank you for trusting me to chair the steering committee for the last year and the other year as a co-chair. I thank you. I have worked with you very well, a good cooperation, and I'm still with you. Thank you very much, and God bless you.
Great. Thank you, David, for your concluding remarks. Well, I just want to say, we should all give ourselves another round of applause for all the work we have done so far. And it's not the end of the journey. I'm very much looking forward to working with all of you on another exciting new year. Let's just keep the momentum going and making greater contributions to the DSI society. And I look forward to greeting you again in the next year's annual meeting in a beautiful island. You all know where that is, right? Thank you very much. I look forward to working with you closely through the steering committee work and all the other occasions through the next year, exciting new year. Thank you so much.
Before we move on, I think we should clap also for David being our chair over the last year. Thank you, David, for everything you've done. And I think you've put us in a great position moving forward in this next year. I have to say, I'm a little sad that the meeting is coming to an end. I think just like last year, I wish there was another day or two or week that we could all spend together. I've learned so much from all of you, and we'll continue to learn more and more every time we meet and every time we interact. So thank you for that. Please know that NIH staff are here to support you. We're here to talk if any issues come up. Please don't hesitate to reach out, and just know that we have your backs and your success is our success. And I really look forward to seeing everything that develops over the next year. I have the great fortune in this closing session to announce the winners of our early career research poster presentations. I would like to thank all of our judges that participated in and helped us come up with our winners. Honestly, all of the posters were phenomenal. The presentations were great, and I hope all of the trainees feel like they got a lot out of this experience. I think the trainees are one of the most important part of the DSI Africa Consortium, and we look forward to integrating them more and more into these meetings in the future as well. So maybe let's clap for our trainees. All right. Can I read the names? Okay. So we have some small prizes for these winners. We can only award prizes to the top 3. We'd like to give them to all of our presenters, but our 3rd place prize goes to Nicholas Brian Brink from the Heat Center. And if Nicholas is here, he can come up and get his prize. Are they here? Oh, good. Great. He's coming around. Sure. Our 2nd place prize goes to Joy Akatope from the DS Change training program. Congratulations. Yeah. And our first place poster presenter, Joy, stay up here. Thank you. First place goes to Aliki Edgecombe from the DSI Africa Law Project. Sure. Yeah, we could do that. Yeah.
The podium, you'll have to come in the middle.
One last round of applause. Thank you. And I'll hand over to Michelle Skelton to say final words for the meeting.
Congratulations.
Thank you, Michelle.
Thanks so much, everyone. So yeah, you left with me now. So thanks to all the participants for your positive energy over the week. Yeah, it was quite a long week, some folks were saying, but thanks so much. And I just want to say thanks to David. He's been a gracious host, really been a great support to the coordinating center, and I have a small gift for him. And then yes, and then wow. And then Shinfeng, it's been really great getting to know you. We've just been talking online and this was really useful, and we'll work together in the year ahead. So thank you so much. You also get it too. You also get it.
Okay. I'll put it on right away.
Yeah, please do, please do. And then to Laura and the NIH team, thank you so much for always being ready to meet, troubleshoot, and being supportive, you know, with the NIH strategy, keeping us on track. It's really useful. So thank you so much for that. And you also get a hoodie. Thank you so much. So, and then to Nikki and Samir from the Alwazi ODSP, thank you so much also always for checking in. We have our weekly meetings, always being a great support running up to the meeting as well. And then to my team, can they come up, please? Daniel, Tino, Rolanda, Francis, Shauna, Ashley. So you guys have been awesome. I don't have hoodies for you now. So thank you so much. You guys have been awesome through the highs and lows. This particular time, it's been difficult. Folks have been getting sick, but we made it here. I don't know why Francis is not coming. So thank you so much and for staying positive and getting us through this. You guys have been awesome. Thank you. So thank you, everyone. And I'll bring this third meeting to a close and see you next year in person, but online. Do you want to? We'll hand over to Joyce and then see you online. And I just wanted to say, I really like what Amina said in her speech about open communication and investing in relationships and cross-learning. I think we really do have to be open to that and accommodate each other online and, you know, just listen to each other and give each other the space. It's a bit difficult space to be in, but we really do need to listen to each other. And yep, so I'll hand over to Joyce.
Yeah, thanks, Michelle. And I want to appreciate the PIs who have given me this opportunity to be part of the steering committee. First of all, to be part of the steering committee that was NIH because of the funding that we just recently got for RU01. So for me, it's like a great opportunity. I haven't attended any steering committee meeting before, so I'm going to have to learn a lot from my chair, but I want to thank the PIs for the opportunity they have given me to learn. I think it's going to be a learning process for me to learn through this year. And yeah, so I look forward to working closely with you throughout this year and the next year, 1 year. Thank you very much.
One last announcement. So one last announcement. My apologies. So those of you who have attended the synthetic data workshop, you have a special gift, the certificate. So you can get your certificate from Francis at the back of the room. So make sure you get that before you depart. That's it.
Yeah, thank you. So thank you all, and we bring this meeting to a close, and I wish you safe travel back home.
Thank you.
Yep. Is this you? Whose watch is this? You got it?
Joyce?
Yes, yes.
Joyce or Joycey?
Joyce.
Joyce.
Yes, Professor. Yeah.
From
Uganda.
Uganda.
Yes. Yeah, I think we had the same panel, so we kind of met online as
That's
we're
right,
preparing
that's
for the panel.
I know,
Yeah,
right, yes,
yeah. So again, it's an opportunity.
Fantastic.
Yeah, to be part of the steering committee. So you probably have a lot of work to do for me to learn and catch up.
Yeah, me too.
Thank you, David.
Yes.
Yeah.
So welcome to steering committee.
Thank you very much.
It's not this part. Just schedule time.
Yes.
Yeah, for attending meetings. You work with the meeting center. It's always preparing everything.
Yes. Yeah, very, very helpful. Yeah.
That'll be great. Thank you. Thank you for volunteering.
From Makere.
Oh, okay.
Makere. Asante.
I
I don't know say anymore. I know that one.
You know Uganda.
No, we got that one actually on discount.
Yeah. You guys, it was 5, 3 get 1 free.